All right, so I will let everyone in.
Yeah.
Just give me one second.
It's funny how we see different her, but I think that's how she wants to see it. Only that be bigger. Yeah.
Okay.
Okay, cool.
Perfect, ready to go.
Beautiful, thank you. Oh, hi everyone. Helen here, and this is now the 42nd of our collaborative series of webinars, which are brought to you by Rural Health West, Rheumatic Heart Disease Registry Australia, Heart Foundation, and Accra WA. So thank you for coming today. We have people from the Kimberley, the Pilbara, from the Southwest, from Metro, and we also welcome quite a few Eastern States people today, and quite a number from Queensland. So thank you for joining us. I'll start by acknowledging the traditional owners on whose lands Nicole and I are today, and that's the Whadjuk people of the proud Noongar Nation. I pay my respects to their elders, past, present, and emerging. I pay my respects to their courage, their resilience, their wisdom, and their gentle spirits. So I have with me today Nicole Skavik. And Nicole is the WA Country Health Service Rehabilitation Clinical Nurse Specialist working in the new Heart Health Support Service, which Nicole will tell you about along the way today. We have asked, you'll see in the Q&A section, please pop any questions in the chat. We're happy to answer along the way if you raise your hand, and we'll also answer at the end. So great to have you with us today, and I'm going to pass you over to Nicole. Thanks.
Thanks, Helen. Hi, everyone. Thank you for the introduction.
Sorry.
No.
My apologies. Taylor from Rural Health West has a very short poll for you. So if you could just submit your responses to this poll before we start. Thank you. Can we type it?
I think we have to.
Yeah, we'll respond to. Okay, good.
Right, we right to go? I think so.
Yeah, perfect.
Cool. Thanks, Taylor. Thanks, Helen. Hi, everyone. Thanks for coming along today. As Helen's already introduced myself, my name is Nicole Skavik, and yeah, I'm part of a new program that WA Country Health Service has started called Heart Health Support Service. I'll talk to you a little bit about that later on. And yeah, Helen has asked me to do a bit of a talk today on cardiothoracic surgery. So today what my aim is more so to, because we have people from all sorts of areas today all over the country, as Helen said, but I'd like to be able to more so share some insights on the challenges that patients and care providers find both before and after open heart surgery, and the disparities of living in a rural community or rural setting can add to this already very difficult life event. So some of those challenges are quite unique to the rural setting. And yeah, so I just really want to, my aim is to give a bit more of a patient perspective on that journey. So feel free to ask some questions in the chat, question and answers there as we go. If time permits, we'll get to them, but we'll have a bit of time at the end as well to get through that. So I'm going to talk a little bit about some very basics of open heart surgery. As I said, some of the challenges that living in a rural setting will add to that. I'll talk about a case study from one of my wheat belt patients. We'll call him George. And how we can minimise some of those challenges that we're facing. So, just go here. All right, cardiothoracic surgery. So we've got a wide array of participants today from varying modalities of health. So we've got nursing staff, physios, exercise physiologists, medical staff. So it did bring me to wonder how to target this talk, I guess, today. And that's what brought me really to want to focus on what the patient experience is and what my patients express to me is the more difficult parts or what their journey is like, rather than talking about, the medical progress. So we all understand what cardiothoracic is, but I guess, do we fully understand what the impact on a patient and their family can be? So the majority of our open heart surgeries are obviously coronary artery bypass grafting or CABG, heart valve surgery repairs. So a bit of a background and a basic understanding about a typical open heart surgery journey. The surgery can be planned. It can be unplanned. Each will bring its own complications. The significance of this is in the ability to prepare for the post-operative recovery, and it also influences the type of emotional responses or the emotional impacts on the patient. So by preparation, what I'm talking about there can be from an emotional perspective, a financial perspective, organising their home, organising work. It can also, it's quite common to instigate people to want to review their end-of-life plans as well. They may not have been through or had to challenge such a, such a big sort of medical challenge before. Recovery for open heart surgery is very variable, obviously. So depending on comorbidities, post-surgical complications, etc. But a typical hospital stay will be between 6 to 10 days, depending on some of those things. The surgery involves breaking the sternum, so very strong bone, which normally takes up to 3 months to heal properly. Patients are quite deconditioned, significant loss of muscle mass, and varying degrees of post-surgical pain as well. So recovery is also quite, as a lot of you would know, it's very dependent on how much patients can engage and adhere to some of those physio recommendations as well. But most patients, when you think about it, it's about 6 months out of their life really that they feel, before they start to feel normal again. So, that's a significant chunk for someone. Wound care, there's some massive wounds in which the healing's often complicated by many of the comorbidities that our patients have, such as diabetes. And then we have the larger, very large wounds, the sternal wound and the graft, etc., etc. One of the more common complications post-surgery would be arrhythmias, particularly atrial fibrillation, and this in itself will instigate the need for lots of changes to medication and increased need for more frequent post-surgical medical reviews as well. Medication titration. So this can be quite complicated in the post-surgical recovery. Patients undergoing heart valve replacements often require warfarin. This can be lifelong or for a period of 6 to 12 weeks, dependent on the valve and arrhythmia complications, etc. And it requires patients to have what's called an INR test. It's an international normalised ratio, that stands for, and basically it's the standard is that it does, in the early stages of starting warfarin, it's very commonly quite hard to get that INR stable. So it means varying dose changes, lots of blood tests, etc. I'll talk to a little bit about that more later. But what can be the most impacting on the patients is most often not the physical recovery, but the impact on the well-being of the person. And some of this you'll see on the right of the screen there. Are dependent on these types of things. So what sort of baseline did they already have for their mental health? How's that going to influence their recovery? Do they have a load of external stresses already that they need to, or lots of, commitments before the surgery? So these are the types of things that, we tend to skip over, I guess, in our constantly, in the areas in which we're so time poor. Sometimes we tend to skip over some of these things. But we know that this is harder in rural and remote areas. And how do we know that? It's because of outcomes, basically. So we know that the level of cardiovascular disease is relatively similar from rural and remote and the metro areas, but the outcomes for patients are poorer. So, looking at why that is. And the other thing that plays a big part is cardiac rehab, okay, that post-surgical recovery and support. Cardiac rehab generally in Australia is as low as 10 to 30% of cardiovascular patients being referred to cardiac rehab, dependent on the region. But the rural setting is where we see those barriers. So what we want to look at is what's different in the rural setting that's going to be for a patient journey from a patient that's living in the city area. It can introduce really unique challenges. Many of these are just due to distance, but some of them have their own other reasons as well. So firstly, the access to specialised healthcare facilities and personnel may be limited. This can make regular follow-up appointments more difficult and urgent care for complications that might arise more complex as well. So transportation can be a significant issue. Long travel times to clinics or hospital can pose both physical and financial burdens as well, cost of petrol. And additionally, socioeconomic and cultural factors unique to different communities as well may also reflect on someone's recovery or and rehabilitation. They have to leave their family behind. So recovery often requires patients to stay in the metro area for 2 weeks after their hospital stay or more to be close to emergency care if needed. And I think a good way to look at that is if you just think about yourself, if when you're sick, it might just be from a flu or a cold, what do you want? You want nothing more than to be in your own home. You want your loved ones there looking after you. You want to be in your own bed. And I don't have that, luxury, I guess. One thing we quite often see on a discharge summary, please see your GP within 5 to 7 days after your discharge. Well, do you know how long it can take to get an appointment in some rural settings with your GP? It can be 2 or 3 weeks dependent on the area. and patients will often not advocate for themselves when making those appointments. You know, that just the necessity of that appointment, that they need an expedited appointment as well. So we have some amazing GPs in rural WA, but the reality is in rural WA is there's a very itinerant group of GPs, which impacts particularly on chronic disease management. So people don't get that opportunity to establish good rapport and frequency and length of time with their GP before they're moving on. And country people really like to feel comfortable with people that they feel are engaged with their community and know the community, and these are the people that they feel comfortable with. So that's more difficult for a lot of country people. The driving is the big thing. So it's tiring driving to Perth. Well, in WA here, Perth, for follow-up appointments. You know, they'll quite often have to book overnight stays, or if they're driving, they get back when it's dark, and all of that stuff is really tiring and exhausting when you're in a recovery period. So we have really good quality healthcare in urban areas in Perth, but the access can be considerably limited in rural and remote areas of WA. It's not also just cardiothoracic follow-up that these patients require. They've got cardiology follow-up, and then if they've got other comorbidities, which is highly likely, diabetes specialists and that sort of thing. So, you know, it can often require at least 2 or 3 specialist appointments. I've just got a question there.
Yeah.
Normal thoughts.
How long after surgery are patients able to return to drive? Yes.
Yeah. So that is one of the things, I think, on our next slide. Good question.
Right.
So yes, the non-driving period. After open heart surgery, you have a minimum of 4 weeks, non-driving. So it then is up to the discretion of the cardiothoracic surgeon generally, but minimum 4 weeks. Most cardiothoracic surgeons will suggest non-driving until patients have their follow-up appointment, and at that sort of stage is when they might review how they're going and give the okay. So generally the appointments are 6 to 8 weeks in the end. Yes. So then the driving period then just automatically gets extended as well. So they're probably, having an extra couple of weeks added to when they, would actually be okay to drive. So yeah, good question. And the other thing to consider is commercial driver's license as well. So obviously rural areas have quite a higher ratio of patients working in industries where they're going to require a commercial driver's license. And then we're looking at 3 months basically. So, getting back to work as well without a driver's license is really difficult. So that distance as well, people in the city, if they're in this non-driving period, will quite often, ask their neighbour or, a friend to drive them to an airport, to drive them to an appointment. But, I don't know, I think I'd be stretching my friendships a little bit if I was asking them to drive 3 hours one way and 3 hours back and also wait 3 hours for me for an appointment. So, all of those things make a lot more difficult. One of the big things that gets posed or gets put forward is people that have properties with animals and, trying to keep the farm running. It's not just a matter of, like we have the luxury here, lock up and leave with our here. So, or asking your neighbour to feed the cat. It's there's lots of requirements for keeping the farm running. So that in itself provides a lot of stress and external stresses as well. The I've got there about fewer services as well. So a lot of, dependent on the area, the local service might just have a GP, and that GP might have lots of other duties and requirements in the community, where we might have the luxury here of having a practice nurse to do wound care and things like that. So it's really, really stretched for the GPs in some of these communities. And what was I going to say? Health literacy, a big one. I couldn't find where I had heard it from, but I heard some really alarming statistics about the health literacy of wheat belt people, being that of I think of about a 9-year-old was the average literacy. So taking that into consideration is really important as well. How does the patient understand? Like, have we presented to them in an appropriate manner what they're about to go through, or a culturally appropriate way as well? So low literacy levels that we know is generally more common in the rural settings. This quite often leads to tie in with that. We see poorer engagement with health services in people with low literacy, poor understanding of their medications, and higher rates of non-adherence or improper usage of their medications as well, which then is going to affect their outcomes as well. Mental health. Okay, I think it's pretty well known that rural settings generally have a poorer mental health. Social isolation and loneliness are a couple of the things that will contribute to that. And with that, poorer mental health also brings a higher amount of those risk-taking behaviours as well, or I guess risky drinking patterns, or illicit drug use and things like that as well. They're all higher in areas or with people that already have mental health issues. So it's the mental health specific services as well in these communities. So much of the mental health care will fall back onto the GP. There are some really good mental health services in rural areas, but obviously, again, it depends on the setting. But most of the mental health care does fall back onto the treatment from GPs. So I feel for the GPs. And another one. So I will talk about this, the challenges in taking warfarin when you live in the country. I'll talk about this a little bit more when we talk about our case study with George. But some people need to get, as I mentioned before, starting on warfarin is quite commonly very labile in those early days. So there might be the need for people to get a blood test to check their INR every 2 days. And I don't know about you, but it would take its toll on me getting out of bed, getting ready, go into, driving every couple of days to go and get a blood test. So, that can be quite an impact as well. And emergency care. So when something does go wrong, what are the services? We have, metro area. It doesn't take more than maybe, 10, 15 minutes to get to a tertiary hospital, but it might just be that, the services are very minimal at their closest area.
Just to say that, yes, the people can get in touch with the Australian Centre for Heart Health with their wellbeing programmes and the Mind CVD information, and they can receive telehealth appointments then.
Yeah. Yep. So I'll talk about some of the ways that we can challenge those difficulties as well. Yep. Just briefly, what have I done there?
That's it.
Just briefly, so I've talked generally about the challenges of people living in a rural community, but then our Indigenous patients also have their own unique challenges as well. Some of those might centre around cultural or spiritual beliefs, and this can be challenging going into surgery as well. You know, we've all come across Indigenous patients that are very fearful of going into surgery at a tertiary hospital. They may have had loved ones that have had poor experiences. And one of the big problems that I come up with is in that follow-up sort of period is getting patients to get back for their outpatient follow-ups. It's been very hard for them. It's been a long time out away from country, and they get back home. They don't want to go. They don't want to come back to the city for that follow-up. And so there is quite a high DNA rates for patients for Indigenous patients coming back for their follow-ups. Also the environment, where are they recovering? How many people are living in their house when they're recovering? Is it a very noisy environment? So sometimes, as we all know, in that community living, you know, that can be quite challenging as well during that period. Then they maybe feel like they need to get back into looking after the grandkids and some of those types of things. And ideally, you know, it might not be the physically the right time for them to do that. So there's all those types of things as well. And then cardiac rehab referrals. So other than their medical appointments, GP appointments and surgical follow-ups, cardiac rehab basically is where we come into all that nursing, physio, OT sort of follow-up. So all of that aftercare, when we know there are such poor rates of referral to cardiac rehab for Indigenous patients, and the participation rate unfortunately is low as well. But you know, they're then not getting that aftercare as well. So that's another one. So I'm not going to read through all of this, but you guys can have just have a read about. This is one of my patients. We'll call him George. He lived in the wheat belt. He's a patient of mine that I first started seeing about 2 months ago, I think. So he was an elective procedure. He was an elective mitral valve replacement, and he also had a bypass. So you can see there he's got a long past medical history of both cardiac conditions and, you know, looking at some of the cardiovascular risk factors. You can see there he's obese. He's an ex-smoker. He does drink alcohol. He's got some heart failure as well. I thought he had type 2 diabetes, but maybe I can't remember. Maybe I might have missed that out, or I may be mistaken. So surgery went okay. His post-operative period was okay. He did have a bit of delirium. He did have atrial fibrillation, but he had a history of that. Discharged, had to stay in the metro area in Perth for a couple of weeks. He was recommended to see a GP in that time in the metro area. So he'd be seeing a GP he doesn't know to check his bloods. And he was started on warfarin as well. So he had to remain on the warfarin for 6 weeks, and he was then to commence an oral anticoagulant. And he was recommended to check his INR 2 days post-discharge. So first of all, he needs to source a GP that in a city where he doesn't know anyone. So after discharge for George, his first INR after discharge, I don't think it was his first actually. So it was when he got home. He had his GP check his INR. He didn't hear back from the GP about what the INR was. The GP apparently got called out to a car accident. So these days as well, we have cardiothoracic nurses that will follow up by telephone with patients in those early days post-discharge. So they thankfully, they will be in touch sort of before the cardiac rehab gets on board. His wife doesn't drive. His house is 35 kilometres from where he has his INR done with his GP. He didn't know the GP because he didn't really have any rapport with the GP. He wasn't one to really to go and see this new GP that was in the area. And the GP was really struggling as well with this. So for 6 weeks, he had to go for second daily INR, and he was continuously subtherapeutic. The GP was really at wit's end as well. So it was at that stage, I think, is when I came in, and basically found out what was going on, got in contact with the Cardiothoracic Registrar, and in the end result was basically he stopped his warfarin a little bit early and commenced on a PICC span. So other things he was having issue with, it was too far for him to join a cardiac rehab exercise program, 35 kilometres out of town. He also got a wound infection, that's right, on his leg wound, and was started on oral antibiotics. He was having some hypertension. And then along that road somewhere is where he engaged with cardiac rehab. So cardiac rehab for George. He was suffering from hypertension. So George participated in video link consultations with me. I'll talk about that in the past, but he had some issue with hypertension. Where are we? He was self-monitoring at home. Initially on discharge, his blood pressure was low, so his antihypertensives were withheld, but George noticed that it was creeping up. So I've given him, these are some of the resources that are available by National Heart Foundation. So I provided him with one of these blood pressure diaries just to jot down. He wasn't writing down his results, and just so he could see the trend and also take them to his appointments with him as well. And then obviously education, lots of education. So I won't go into the details about it, but that it did include he was in need of lots of dietary education. People in the wheat belt eat a lot of lamb, and they're not lean cuts either. So I encouraged him to also access the National Heart Foundation dietary resources that are online, which he'd done. Alcohol intake was one for George. So I initially counselled him about alcohol and the contraindications with him taking his warfarin. So needless to say, he was quite happy when his warfarin stopped. But it did take a bit of convincing, I guess, for him to see that it was also should be considered a risk factor for his ischemic heart disease as well, and his atrial fibrillation. So, and then the fact that he couldn't attend cardiac rehab exercise programs where he was. This was me, I guess, fell back to me giving him some quite basic exercise advice, reiterating those sternal precautions, giving him some suggestions about getting back to exercise safely, and not just keeping busy on the farm, I guess, which is something that I've faced a lot. Yeah. Depression. He was very low in mood. He was very frustrated with the challenges that his labile INR was giving him, and the driving, and remembering this was also still in his non-driving period, and his wife didn't drive. So I will leave you to your own conclusion as to how he was getting to have that done. But I guess identify the important thing, I guess, is identifying first initially, and I think this is something that's maybe not looked into as well, that in the pre-surgical period is identifying those pre-existing mental health concerns, and identifying that this may be an issue in recovery, and just letting patients know, I guess, that this is a really common period of time that they may have exacerbations of previously well managed mental health. So even just identifying that, I think, is an important thing. And so part of the cardiac rehab care from a mental health point of view is really encouraging those general things that we know are good for mental health, like good diet, good dietary intake, exercising, those types of things, but just talking as well. So talking about the cardio blues being a normal thing. So a really interesting statistic I find is that cardiac blues, 75%, it's estimated 75% of people experience the cardiac blues after a heart event. So even just this can range, I guess, from unexpected changes in mood. Patients are sad, tearful, they can just start crying on a whim. They can be angry, irritable, worried, anxious, confused, all of those things that you can see there. And then also sometimes with that start creeping in some periods of forgetfulness and confusion, which comes from that high stress load. But patients that aren't too aware of that will start wondering if they're going a bit crazy as well. So resources, I guess. We know that in rural Australia, it's very variable, the on ground, I guess, or the mental health services that are available. As I said before, there are some really good mental health centres. The Wheat Belt, for example, here in WA does have a really good mental health service, but lots of online services as well. So National Heart Foundation has lots of resources as well. What was I going to say? The other one, the Australian Centre for Heart Health has a very good mental health component as well. Some good resources there, which I use quite a lot. But just talking and acknowledging with patients as well of what they're going through is sometimes just enough.
And I see the importance of assessing with your PHQ2 and your PHQ9. And then that in itself has a referral, depending on the scores you get, that you would either refer on to someone, or you might be able just to carry on with those conversations and check in at each appointment.
And that PHQ or a screening, I guess, for depression or anxiety should be something from a cardiac rehab perspective. It should be something that's included. It is an ACRA recommendation or guideline that we do include that in our assessments. So it's important, I guess, to make that differential of cardiac blues, and then if you have concerns that the patient might be lapsing into a period of depression or anxiety. Rural Link is another good service. So they have an after-hours telephone service for people in rural and regional Western Australia experiencing mental health crisis. Their service has some hours, I think Monday to Friday it's open business hours, hours. Have I put the number on there? Yep. But they have extended services over public holidays and weekends. Yeah, so but that's I guess a necessity of, you know, finding out what's available in those areas as well. Okay, so how do we minimise the challenges, I guess? So it's tricky, but how we need to look at how we can optimise the outcomes for our patients recovering from surgery. There's lots of strategies, okay, lots of things we can wish for, but there are some, you know, some good strategies that we can put in place to overcome these challenges. One of them is technology. If anything good came from COVID, is that Australia started to get a lot more on board with increased use of technology in healthcare. Telehealth services are really encouraged by the WA Country Health Service. It is one thing that's really been pushed at the moment, and it can be a real game changer for people living in rural WA. Remote consultations can significantly reduce the need for long-distance travel, and it allows patients to consult with their Perth-based cardiologist from the comfort of their own home or nearby health service providers as well, so attending to nearby hospitals or health centres to have some telehealth. But it does also require people to advocate this for patients, and it's something I guess if it's clinically appropriate, obviously, but it is something that I do find challenging, that there is this automatic sort of follow-up appointments made without any consideration into the patient's needs, where the patient lives. They're just these automatic follow-up appointments made in Perth or in the tertiary hospital. So I guess taking some responsibility from caregivers in the during the surgery or in that recovery period inpatient, to advocate for patients if that is an option. Yeah. What was I going to say? So, monitoring. So, although we're not as yet, there are lots of cardiac rehab programs that are using remote patient monitoring systems as well. So these are really of benefit and something that we'll probably be getting on board with at some stage. So these can provide healthcare professionals with real-time data and numbers on patients' progress, enabling early intervention if any issues arise. And patient use of technology as well. So there are some new programs around for patients to monitor their progress as well. With the use of dedicated apps, patients can keep track as well of their medications, their diet, their exercise, their appointments. They can get reminders. Some of you in the cardiac rehab space might know of CardiHab. They've been around for a little while. I think Christine from CardiHab, well, I did see was
Christine on.
Yeah, yep. She was logged in. Hopefully you're here, Christine. But yeah, Christine and CardiHab are just getting on board with the Heart Health Support Service here for WACS as well. And it's in its very early infant stages, but just introducing that for our patients as well. What else did I have? Investing, I guess I actually haven't put that on my dot points, but also investing in the upskilling of local healthcare staff, such as nurses and doctors in the rural setting as well, just so they feel well educated and confident with providing that appropriate care as well. And I think the other thing to realise is that, depending on what area you're working in, you can't know what all the services are available in these, in your areas. But one thing that can be of benefit if you feel concerned about a patient, if they might need that little bit of extra support. Chronic conditions services in country areas are particularly good here in WA. And of course, making sure your patient has got their cardiac rehab referral. So it is one of the things that can be difficult in that rural setting, you know, is knowing just what services are available and if they're still going, if they're still getting, if they're still funded. You know, that gets pulled out from us quite a lot. Engaging with local Aboriginal health services is also really important. So your patient might have a better relationship with people at these services, but also identifying things like that you might suspect may be an issue. If transport's going to be an issue for the patient, they might, you know, that can be identified early and you know, reduce that risk of patients not attending for their follow-ups. And also, I think with our Indigenous patients, preparing them well, preparing them for their surgery well. So making sure they understand in a culturally appropriate way, in a health literacy appropriate manner, what to expect. So, and we all know when we go into something major like this, that the better we're feeling, the more educated and aware that we're feeling, the more confident we're going to feel when we come out of it and start. If we feel good, our recovery is going to be better. There's also I know a lot of the tertiary hospitals will have some services. Fiona Stanley, I know, has got a welcome to country for available for Indigenous patients, and using obviously your Aboriginal liaison services in your tertiary hospitals is really important with that as well. So. Do you want to have a little chat?
I think I did see, and I think you may have answered it. There was a question up about financial support. And in WA, we have the patient-assisted travel support. So I didn't know if you wanted to. That can be done prior to leaving, or if it's known that you're going to have the surgery, that be initiated to get you to the tertiary hospital, and then that all starts to happen. Emergencies it can be a bit more timely.
That's right. Yeah. So the PATS, here in WA, we have the Patient Assisted Transport Scheme, which does financially assist patients with both, it can be fuel, accommodation, those types of things. What I would encourage with that is making sure all your ducks are in a row as early as possible, because that in itself can be tiresome for patients. That follow-up, the chasing, reimbursement, chasing if the form's not signed properly, those types of things. So it's not a foolproof service, I guess, and just making those realizations of the stress sometimes that when those things aren't properly organised before, that in itself, can become a bit of a stressor during that recovery period.
Definitely. And I think that's a lot of what you've alluded to, is that vulnerability of patients. Having heart surgery, you face your own mortality, and your thought processes aren't definitely how they would be when you're well, and not coming from that fear-based emotions. So, and as you've said, it's really important to come from that person-centred approach, where it's what matters to you, how can we help you as an individual, and that's really important. And also, and especially thinking of our First Nations people, to come from that trauma-informed approach, because there's so much fear linked with what's happened through colonisation, etc. And then just if we do think we're going to help, and like George had some depression and anxiety before. It was a bit of a double-edged sword, but his go-to, it sounded like, was alcohol to help him through times of stress. So it's really important that we use that person-centered, trauma-informed approach, and then actively listen and use all those motivational interviewing and teach back techniques that are used in cardiac rehab, the goal setting, small steps to being able, and using that education and working as part of an interprofessional team wherever that's possible, but in some of the smaller country areas, and knowing who to refer to is really important. So I think we've covered a lot of that, so it's fantastic. And we might just also, really important, it's always been my thought, if we get things right for Aboriginal people, then we can potentially get it right for everyone. Because Aboriginal people are all about mind, body, spirit, and nothing works on its own. So that holistic care of not just looking after physical, but physical, emotional, psychological, spiritual, cultural, that holistic care, and recognising the connection to country, especially for people out in country areas where walking on Mother Earth is really important to them. It can be their livelihood, it's their whole community involved in their care.
Grounded.
Yeah. So I think that's really important to factor all of that into care for each person. And I think we're getting close to time for questions, so please have some ready for us. But if you go to the Heart Foundation, there are stories of people with heart surgery. There are videos of valve disease, bypass surgery. There are lots of other resources. There's the Cardiac Rehab Directory. And if your service isn't in this currently, then please make us aware of it, because we don't know what we don't know. And we need you to have that documented so people can look in the directory and find your service. There are lots of information for health professionals in cardiothoracics with webinars and different resources. And from a cardiac rehab point of view, and especially in rural and remote, and again during COVID, Heart Foundation have some personal walking plans, which is your apps that you were talking about, and it uses motivational techniques through the app. And, this can be helpful when you maybe are isolated. And if you're in a community that is bigger, after your cardiac rehab, you could form a walking group. And yes, so.
I think we had a question.
We've had a few little questions.
Yeah. So we've got a question here from Lauren. Do you know if many patients are referred to dietitians? What are the main reasons for referral, and whether patients follow up with these referrals? Dietetics is one of the more difficult, I think, of the modalities in the rural setting because of funding. Basically, there's not, there's not a lot of dietitians, I guess, in the rural communities. There are some really good program, community programs. I know in WA we have a program called the HEAL program, Healthy Eating and Lifestyle, I think that is, which I've had good feedback from patients from. Overall, there's not a lot of direct referral to dietitians unless they're going through post-surgical, that they're not, that they haven't recovered well post-surgically with their appetite and they're having weight loss and so forth. If it's a general diet education, that would fall back to cardiac rehab staff or some of these other community dietetic programs, but there's not a lot of dietetic support, I guess, as an allied health service in the rural hospitals, unfortunately.
Is there a telehealth service, nutrition telehealth type service anywhere?
Not that I know of, no. No, there are there's some telehealth diabetes follow-ups and things like that, which include the diabetes dietitian. Yes. Not that I know of any specific.
Cardiovascular. So if anybody on the call today knows of any telehealth diabetes services,
dietetics,
please make us aware. Yes, not diabetic. We Diabetes WA have those programs. But have we got other questions?
No, I think we answered the other questions. That was about the PATs. Yes. I think that was about it. So cardiac rehab in country WA. So as I sort of said at the start, the Heart Health Support Service is the service that I'm running here through WACS. And it's a new service. We only started patient contact in October last year, but it was a service, I guess, that was devised from the clinical telehealth development team in WACS after recognising the disparities that cardiovascular patients living in the country had. So we've rolled out initially into the wheat belt region and more recently into southwest of WA. It's modelled on providing virtual care, so care either by telephone or telehealth consultations. And some of the, I guess, differences in the program is that it's a much more flexible sort of model, much more patient-centred model of cardiac rehab. We're still in the project phase, so but things are going really well. And where the long-term goal is I guess to provide a centralised, I guess, sort of cardiac rehab service with and roll out, I guess, to more regions in country WA. But it's certainly been challenging learning about those rural challenges, but it's been a great opportunity to learn, I guess, about what other services are available in country WA. So I've certainly learnt a lot there. If you are local in WA, you've got country WA patients. If you're in public health, we are on e-referrals via Bunbury Hospital. Don't ask, it's too hard to explain, but it does have to do with us being in that project phase still. But you'll find us under cardiology at Bunbury Hospital, or you're welcome to email me and I can go from there with you. About it.
And you're listed in the cardiac rehab.
Oh, we are, yes, we're listed in the cardiac rehab directory, also on health pathways for other medical staff, I guess. And I think that's about it. Any other questions from anyone there?
Nothing.
yeah, if anyone has any stories or suggestions or input.
Happy to take that. Otherwise, I'd just like to thank you very much, Nicole. That was really fantastic insights to some of the problems, yes, which are many, of living in the country and all the extra barriers to recovery that exist for George and other people out there. So thank you very much. Thanks everyone for joining us.
Thanks everyone.